This is my presentation on my GPS project titled The Development of Predictive Risk Models for All-Cause Mortality in Pulmonary Hypertension Using Machine Learning. Pulmonary hypertension is a progressive lung disorder, and it results in symptoms like shortness of breath, loss of exercise capacity. It can result in various complications that can be quite debilitating, like infections or hemorrhage, and ultimately result in premature it can result in heart failure and ultimately in premature mortality. So the goal of this research project was to try to produce a model using a less conventional method to predict the mortality in patients with pulmonary hypertension. So looking back at some existing models for predictive risk of pulmonary hypertension, these include the National Institutes of Health registry-derived first prognostic equation, the Risk Evaluation and Education for Alzheimer's Disease Studies model, which uses variables like pulmonary vascular resistance, portal hypertension, age, and the Scottish Composite Score, which uses variables like age, sex, right atrial pressure, cardiac output, and 6-minute walking distance. And so these are existing models that we have for predicting the risk, various risks such as mortality in pulmonary hypertension. However, this study aims to determine if some more routine administrative registry data could be used instead to predict long-term outcomes of pulmonary hypertension, in particular, all-cause mortality. So the study was a retrospective population-based territory-wide cohort, and it included patients with pulmonary hypertension in HA hospitals from the 1st of January 2000 to 31st December 2017. And we identified these patients through the CDARS database. And there was also a specific coding system that we used to define the patients with pulmonary hypertension into primary and secondary pulmonary hypertension, and this was the Icd-9 coding. So the way we defined it was patients either had primary or secondary pulmonary hypertension according to the Icd-9. We also use the Icd-9 to extract other comorbidities, and also we use that categorization for other things like hypertension, diabetes, and we used the most common drug classes. We collected data on the most common drug classes that pulmonary hypertensive patients were being treated with. And these weren't necessarily specific to pulmonary hypertension. They were just the most common drugs that patients with pulmonary hypertension were on. So those are listed on the slide. And the primary outcome was all-cause mortality. And we used the Mann-Whitney test for continuous variables. And we also used various other tests for statistical analysis. And we also extracted other data, such as the patient's hospitalizations, if they had any prior or any readmissions, any past comorbidities, and this is the baseline characteristics. So we had 2,562 patients, 1,009 with primary pulmonary hypertension, and 1,553 with secondary pulmonary hypertension. And during follow-up until the end of 2019, there were also some deaths in both groups with primary and secondary pulmonary hypertension. The surviving patients in the end had a similar cumulative number of hospital admissions, number of emergency readmissions, and cumulative lifetime hospital stay duration. So this is a table showing the Univariate analysis to predict mortality of patients with pulmonary hypertension. And the results were ultimately that older age, prior comorbidities like cardiovascular disease, respiratory disease, renal disease, diabetes, hypertension, and gastrointestinal disease, the number of emergency readmissions, average readmission interval, and also various drugs. These were all found to be predictors of mortality for primary pulmonary hypertension after univariate analysis. This is the table for multivariate analysis and the various factors and the significance in their prediction of mortality of patients with pulmonary hypertension. And in multivariate analysis, once again, there were similar factors identified, such as the age, various comorbidities, and the number of emergency readmissions and average readmission interval, as well as the use of a wide variety of drugs. So the predictive scoring system that we ultimately developed was based on these multivariate predictors, and we essentially derived a scoring system for both primary and secondary pulmonary hypertension, and depending on the different factors that they had. So if their age was above 65 years old in a patient with primary pulmonary hypertension, then that would add 2 to their score. And if they had a cardiovascular comorbidity in a primary pulmonary hypertension patient again, then that would also add 2 to their score. And that's essentially how to interpret this table. And we looked at the stratification performance of the score, and what we found, the important part was of this table is in the first row, there's a cutoff value, and we found that that cutoff value was what was significant. And so for primary pulmonary hypertension, the cutoff was 11.75, and for secondary pulmonary hypertension, the cutoff was for 13.23. So essentially above that cutoff in both primary and secondary pulmonary hypertension respectively, that would be when there would be significantly higher all-cause mortality. And we also used various machine learning models. This table illustrates the efficacy of the different machine learning models against one another. And we use these machine learning models to develop the scores. And for the final model that we found to be most effective was the factorization model, which is FM. And the reason why this was the most accurate one was because it had the highest parameters, as you can see, in precision recall F1 score and AUC. Essentially what these mean is that the precision is a indicator of it is the positive predictive value of pulmonary hypertension using the score, and the recall is the sensitivity of the score. And the F1 score and area under curve are kind of measures that are an indicator of that take into account both precision and recall. And so the higher that these parameters are, the more the better the prediction of the score. So that's why we use the factorization model, which had the highest parameters. So we did attempt to submit this paper, but we were ultimately rejected, and there were a variety of reasons. So first of all, there was a lack of data for the there was a lack of data in multiple regards. First of all, the pulmonary hypertension definition, which we used, was primary and secondary as defined by the Icd-9. And the Icd-9 coding was deemed to be not really sufficient as a definition method and a method of categorizing pulmonary hypertension. This ultimately meant that the definition from the start was kind of the definition was not ideal, and it was as a result not very clinically applicable. Furthermore, there were a lack of subcategories which kind of determine the mortality risk, such as the categorizing pulmonary hypertension by etiology. We also lacked data on the pulmonary hemodynamics, and also the factors like the prevalence of right ventricular failure was not investigated. And also, finally, we didn't have data on drug therapies which are specific for pulmonary hypertension. We only had the most common drugs given. And ultimately, a large proportion of these problems were limitations due to the kind of database we used, and the CDAR's collecting data collection only allowed for certain types of data, which didn't quite meet the standards. So we weren't really able to collect hemodynamic data. We could only really collect patients categorized into pulmonary hypertension under codings like the ICD-9. And so as a result, this was problematic, and perhaps the one of the major limitations in our study design was using this database. So as a reflection on my project and the shortcomings of it, or the difficulties in going through this whole process, we did find that based on the multivariate analysis, many of the conclusions weren't really intuitive, such as the various associations with increased mortality in different drug therapies. And the drug therapies themselves likely were not actually the cause of the increased mortality in the patients, but rather patients with more severe pulmonary hypertension and a more severe disease were probably likely to have higher mortality, and as a result were being treated with more drugs. And so that would be a more intuitive explanation for our findings from the multivariate analysis. The drug data that we extracted also didn't really present a complete picture, as once again it was only the 10 most common drugs given to pulmonary hypertension patients, rather than any specific therapies for pulmonary hypertension. Again, this is also a limitation on the database that we use, as it only had very commonly used drugs available, not necessarily ones that were specific to pulmonary hypertension. And we also found that it would be important to compare the machine learning models that we use to the existing predictive risk models to see if ultimately the scoring system we derived would be of any clinical application, would have any clinical application or use in comparison with the existing models. And so ultimately we we could say that a major limitation was also the study design and how we used a database that wasn't necessarily ideal for this type of data that we wanted to collect. So thank you for listening to my presentation.